If someone would have told me 20 years ago to publish any paper on head injury in something called neurology, I will tell him, you are crazy. There was no access to anything called neurology for all of us. Traumatic brain injury was considered to be not even the disease, a social problem, but not a neurological disease, definitely. So we never publish in anything called neurology, except the UK Journal of Neurology, Neurosurgery, and Psychiatry. So thank you very much for opening us a new world. What about the guidelines? The first set of guidelines was published in '96. Many of the people who is in this room, including myself, Nino, Andrew, David, Graham Tisdale, were all involved in the production of the guidelines, which at that time were the first guidelines ever published in neurosurgery. Why? Many reasons. The first one is the more practical one. There is no money involved. We are dealing about traumatic brain injury. At that time, the neurosurgeons were not very much interested in traumatic brain injury, so we could deal with the guidelines in traumatic brain injury, which at that time had practically only a scientific side. They were published in '96. They were translated in about 19 languages, and which is important for the future. At that time, they have tried to be applied in countries with limited resources. Remember, we are talking about '96. So Bulgaria and Romania, which translated the guidelines, have limited resources. So already in the past there has been a tentative approach of adapting the guidelines to countries with limited resources. With the time, we learned which mistakes we have done, or which were the best, the highest problem we had with the guidelines. We were all convinced that guidelines at the beginning are like Bible, is in the stones. You cannot change because it's something coming from a very good evidence-based bench of papers. But for instance, with the CPP limits, we were wrong. At the beginning, we said you should keep it over 70. Then we realized that it was too much and there were side effects. So we changed it. Or when there is a treatment is clearly about common sense, there is no evidence, obviously. Who is going to, I was one of the authors of the surgical guidelines together with American colleagues, and we didn't find any class 1 or class 2 papers, because if you have an hematoma like this, you are not going to randomize this patient to treatment or no treatment. So the evidence-based approach is not working because we don't have evidence-based, like Graham Tisdale wrote in The Lancet, the parachute effect. Nobody is going to randomize if you jump with or without parachute. So we learned that some part of our work is only based on common sense and experience, cannot be based on evidence-based medicine. More, we also learned we had the myth of the evidence-based medicine. If I do review 40 papers, you do the same and you do the same, the conclusions are similar because we are reviewing the same papers. That's not true. Our prejudice and opinion are important. You see, this has been published in February 2013. It's a Cochrane collaboration. Class 1 indication to use corticosteroids in spinal cord injuries. It's class 1. We have evidence-based approach to the use of corticosteroids. 1 month later, this is the joint section of the spinal trauma group from WNS and CNS, the Americans. Yeah, sorry. Yes, sorry. No, I am one slide over with this, but I look there. So this is the American published 1 month later, only 1 month later. 4/5 of the paper review were the same. Conclusion, opposite. Class 1, you don't have to use steroids. Which is the result of these conflicting behaviors? It's this one. You see, this is a survey done in South America. Basically, every neurosurgeon does what he wants, because there is two papers, two suggestions coming from very well-reputed institutions, both, telling you exactly the opposite. So, talking about my topic today, the last few minutes, guidelines, the fourth edition of the guidelines. I have to look here because here I am 2 slides later now. So I have to look here. The fourth edition. Very good, the addendum to the guidelines. This was very good. They have explained what was it before, what is it now, and why they have changed. This is very good. It's not in the guideline, it's an addendum, but it helps to clarify why they have changed each topic. And this is it's good. But what about the clinical side of these new guidelines? Then we all have problems to understand what's going on. The first version of the guidelines put ICP monitoring into a patient who is in coma with an abnormal CT scan. Clear. Every one of us understands which patient is it. But look at the new version. Severe TBI patient using the information is recommended to reduce in hospital and 2-week mortality. Which patients? That's not easy to understand. Or, when we talk about this, the new target, the new cutoff, instead of 20, is 22. I am probably coming from a country too flexible, but 20 and 22 for me it's the same. And it's like you say, I have to catch up my train at 7:25 or 7:27. That's the same. You have to go to the airport at that time, and that doesn't make much difference. So we think it's not. And then the biggest mistake we have done for years, we have said that the ICP monitoring was the only important benchmark to see whether the guidelines were applied or not. And this reduced all the guidelines to only one topic, and it is really difficult to see that even by only using ICP as the indication for guidelines adherence, we basically go nowhere. This is a large American study. So I just jump over these 2 slides and go to the next topic, which I have to go there because here I'm 3 in advance. The decompression. In the guidelines, we have inserted correctly the decompression, and we have said how big should be the flap of decompression in which patients. If we look at the patients, it's very clear. This is the rescue ICP study. You do whatever you want, and then if you cannot control ICP, you randomize patient to medical and surgical behaviors. This is the rescue ICP, just published. Good, perfect. This is very much clear. But if you are in Tanzania, on the right, where they have much more decompressive craniotomy than any one of us can have in Brussels or in Milano, and you don't have anything on the right, you don't have ICP, you don't have barbiturates, you don't have anything, how can you use this guideline? You cannot. Simply, in Tanzania, you cannot do it. But these are the only one we have. And this is Nigeria. What they are telling, if a patient has a mild injuries, but a bad CT scan, a Rotterdam or Marshall score 3 or 4, then I decompress the patient. I don't wait until clinical deterioration because I don't have the ICU. I cannot repeat CT scan, I don't have the medicine, but I have the possibility to decompress the patient. So what they are doing, they are using decompression as a preventive measure. So the conclusion is clear. We have made high-income countries guidelines for high-income countries, not for low and middle-income countries. Or if you tell the people that you have to transport the patient to the proper hospital in a proper manner, and this is an ambulance in India, which is like a small bus with us, with nothing inside, not even, I don't say a nurse, but not even ventilator, nothing. If you have this, how can you apply that guideline? So what I'm saying is that, this is the letter that's to finish. This is the letter we wrote to neurosurgery to comment about the guidelines, and Giuseppe, who is here, and Andrew Mas have done the same. They have written letters in the same line. The basic concern for every one of us that we have lost the clinical side of the guidelines in favor of the methodology. The methodology is fully respected, but clinically speaking, these guidelines are not helping us, and we are following this. If you look, only one thing, in the guidelines, there is no review of consensus conference done during this period. We had 3 consensus conferences. This is one. This is another one, the one we did in Milano. And this is another one, all done by members of the writing group of the guidelines, all of them. 1, 2, 3, to clarify when do we use ICP monitoring. None of them has been taken into the minimal consideration in writing the guidelines. So my opinion is, why should we do consensus conferences? Nobody cares when we operate the guidelines. And these are the comments of the American colleagues who said, you are right. You are right, and we have left this method. We have kept a method which is now no more clinical significance. How do we do in the future? And how do we do in the future? That's the last 2 slides. These are our colleagues from ASCO, from oncology, sorry. This is, ASCO. These are oncology colleagues, and they are telling we have, look here, we have to stratify the guidelines to help our colleagues working in low and middle income countries. These are oncology. How do we do it is a mess. Probably you will be able to help us, because this is, sorry, we are going back. Yeah, okay. How do we do it? It's a mess, because if you look at this, these are all comments done about from colleagues from Bangladesh and telling the colleagues in UK, you shouldn't do like this because it's not helpful to us to treat oncological patients. But this is the future. The future is, in my opinion, that we try to stratify what we do and help it. And we all agree that we need to leave the methodology or change it, the methodology, and keep as a guidelines how do we are helpful, clinically speaking, to our colleagues. Thank you.